Participants. And we're live.
Good morning. I am so excited that you are gathering here today for what is a very important conversation. My name is Isabel Becerra, and I am the President and CEO of the Coalition of Orange County Community Health Centers. Welcome to the Coalition's Coffee Connections event focused on the future of our healthcare workforce, disrupting the system, addressing the crisis, and planning for the future. As you may know, the Coalition of Orange County Community Health Centers is a membership organization that represents the interests of the health centers that serve our community's most vulnerable patients, those who are either uninsured or underinsured and face disproportionate risks due to structural racism and discrimination, and who our public health system often overlooks. Our membership includes 27 community health centers, collectively operating over 70 sites throughout the county and serving over 350,000 patients with over 1 million visits per year. Our members, many of whom are joining us virtually today, provide quality, preventative, and primary health care, oral health, mental and behavioral health, program eligibility services, health screenings, food and rental assistance, and more. Always, again, looking to address the social determinants of health that the patients walk in with. For over 49 years, the Coalition has engaged in the work of building a healthier Orange County. We believe that for our community to thrive, everyone must have equitable access to quality, affordable health care, regardless of income, ethnicity, or immigration status. Raising awareness, providing education and training, and leading a facilitating, thoughtful, and often uncomfortable conversation to enable change is integral to the work of the Coalition. With that in mind, our team has put in place the Coffee Connections events, which are designed to unite and connect, educate, and drive action of health center workforce, partners, Coalition staff, policymakers, and other stakeholders on key healthcare and public health topics and issues impacting the Orange County communities. Through these events, we strive to create a platform in which we have a shared understanding and common knowledge, as well as a space for continued collaboration to further drive actions towards a healthier Orange County. Today's event will focus on a critical topic, workforce. For all of us in the healthcare industry, we continue to face a workforce crisis, which has further intensified since the onset of the global pandemic. We are at a critical juncture in addressing this crisis, and it is evident that the old ways of thinking and operating are no longer sufficient. Competition from non-health companies hiring healthcare workers, career change, burnout, staff shortages, etc., are just examples of the workforce challenges that we face. As such, we can no longer continue to do the same thing over and over and expect different results. As stated in the title of today's event, we must disrupt the system to make changes in workforce. One key element of our Coffee Connections event is for us to create shared language and understanding. And with that in mind, when we think about the word disruption, we are referring to challenging and fundamentally changing traditional approaches, systems, and practices related to workforce development and management. Disruption involves introducing innovative strategies, technologies, and mindsets to address existing challenges and drive positive change. Disruption seeks to challenge status quo and create new ways of recruiting, training, retaining, and engaging the workforce to meet the evolving needs of the community. It can involve rethinking job roles, embracing new technologies, fostering a culture of continuous learning, and creating pathways for diverse and inclusive workforce development. Ultimately, disruption aims to reshape the workforce landscape, improve efficiency, enhance job satisfaction, and deliver better outcomes for both healthcare providers and the communities they serve. So we must disrupt. We must continue to challenge status quo, roll up our sleeves, get into the arena, and become comfortable with the uncomfortable, including having tough conversations within and across sectors. That's why we're looking forward to our Coffee Connections event. and having all of you as our members, stakeholders, partners join us. Join us as visionaries and change agents to challenge the status quo, disrupt outdated practices, and pave the way for a more sustainable healthcare workforce. Again, thank you for virtually joining us today. This event promises to be a dynamic and thought-provoking gathering, bringing together esteemed stakeholders like yourself, dedicated to transforming the healthcare industry. The Coalition of Orange County Community Health Centers truly believes that by actively engaging in meaningful discussions, sharing insights, and exploring innovative strategies and approaches, we can address the critical workforce challenge we continue to face and plan for the future. This morning, we are very excited to have Dr. Alma Sheikh, Deputy Health Officer for the Orange County Healthcare Agency. Dr. Sheikh is a physician and a surgeon who understands that we need to look beyond the walls of the hospital in order to ensure a continuum of care. As a member of the Orange County Healthcare Agency, Dr. Sheikh oversees population health and equity measures, ensuring that every community has a seat at the table, engages the health systems and communities in disaster preparedness, and collaborates to build networks to address violence prevention. She is on a mission to transform organizations, leaders, and individuals toward higher levels of performance while fostering greater professional and personal fulfillment. As if the above weren't enough, Dr. Sheikh is a leadership coach, healthcare consultant, and a sought-after keynote speaker. At a personal level, Dr. Sheikh is strongly guided by her Islamic faith and the desire to leave the world, even if by a small measure, a better place to her actions. Dr. Sheikh, on behalf of our member health centers, welcome to Coffee Connections. The microphone is all yours.
Good morning. Good morning. Just doing a quick audio video check, make sure that everything that you're seeing is appropriate. Are we all good before I go ahead and get started?
Yes, looks good.
Okay. Apologies, just trying to get the technology going. I know I had it up and trying to switch it around. I'm going to ask for my IT team if you guys want to pull up the slides for me, because right now we're looking at the, I think we're looking at the presenter's view. Actually, I'll take it back to control. Thank you. I see that I'm good and I'm good to go. So good morning. I apologize for the technical difficulties, but we'll go ahead and get started. And Isabel, thank you so much for that wonderful introduction. You know, I've spoken before with the Coalition of Orange County Community Health Centers, and I always really enjoy speaking to this audience because we have thought leaders, we have healthcare workers, we have community-based workers, we have everybody that comes to the table. And really, when you talk about this issue that's at hand, the healthcare workforce crisis, it's going to come with a collaborative effort from all sides to really address what is going on. So Isabel, thank you for the great introduction. Thank you for allowing me to be part of this this group so that we can begin to discuss, potential solutions, because I think there's no point in talking about the problem unless we really do have solutions. And to the rest of the team, Sonia, I know you and I have sort of worked a lot on this, as well as to the IT team, because frankly, none of this will happen without great IT support. So thank you all for the opportunity. So just briefly, the objective and sort of what I hope to gain and pass on to all of you during this talk is really to just understand the magnitude of the healthcare workforce crisis. And I don't think that this should be coming as a surprise to really anybody. It's something that's talked about in many different venues, not just here. It's in the news, it's in political spheres, it's in healthcare spheres, it's in the public health sphere. So this should not be a surprise. But I also want to talk about factors that contribute to the healthcare workforce crisis as we see it today. Isabel mentioned, and I will bring it up also, this is not a new problem. This didn't just show up in the pandemic. It's been there since and prior to the pandemic. It's just that the pandemic is what pushed us over the edge. And really, the main part of my talk and the gist of what I'm going to really talk about is to discuss solutions to address workforce shortage and the future implications of that. And just really quickly, I have no disclosures to relay. So briefly, Isabel, thank you for that introduction. I just want to tell you a little bit more about me, and I suspect why when Sonia reached out to me, she asked me to give this talk. I had the opportunity to work in a couple different spaces. I am a trauma critical care surgeon. I am formerly a trauma medical director. I do currently work with the healthcare agency as the deputy health officer for population health and equity. I also have the opportunity to teach at USC as an assistant adjunct professor, specifically in the public health space, addressing quality of healthcare issues, workforce crisis, and all of those things. And also as a healthcare systems consultant. So I say all this to say, I've had the opportunity to look at our workforce crisis from different lenses, from being boots on the ground, from having worked in the hospital, having worked in the front line, from a public health lens, and from an academic as well as a consultant lens. And I think that it allows me to see different spaces, different views, and also potentially look at collaborative solutions. So really quickly, how do we define a healthcare worker? Well, if you sort of look across all of our references, it'll say an individual who's provided healthcare treatment and advice based on formal training and experience. That's a pretty broad term. That includes everybody that's on that list below: audiologists, chiropractors, physicians, medical assistants, physician assistants, surgeons, respiratory therapists. And that is probably only a very, very partial list, because there's so many people that are included in what is defined as a healthcare worker. So when we're talking about a healthcare worker crisis, it's not just about physicians and nurses, which is where our minds go, which is oftentimes where a lot of the research is in, and which is where the statistics are in. But we really have to look at this at the bigger picture. And just having been in the healthcare workspace, I will tell you my personal and favorite definition is the one that's on the image on the screen, that a healthcare worker is a superhero without a cape. So let's take a moment to define the problem. Workforce shortage in any industry, whether it's healthcare, whether it's automotive, whether it's in, the airline industry, it's not having the right number of people with the right skills in the right place at the right time. That's really what workforce shortage is about. And that is what we are experiencing right now, just in larger and larger droves. This existed long before the first cases of COVID-19 were identified in the US, as Isabel mentioned in her introduction. The World Health Organization predicts that we're going to have a 12.9 million person healthcare workforce shortage by the end of this year. And that number was 7.2 million in 2013, just to put that into perspective. COVID-19, again, did not create the issue. It only brought it to light. It really was the breaking point for our US healthcare system, because it brought forward the issues that had already been plaguing our healthcare system. And that is why it is becoming so critical for us to begin to address this with some of the novel, disruptive, challenging ideas that I think we're all here to discuss today. What is currently going on is known as the Great Resignation. It's the mass exodus of healthcare workers since 2020. There's various numbers out there, but 20% of the workforce, which includes 30% of nurses, as the American Hospital Association defines it. And I know most everyone in this audience has probably heard the multitude of stats that are out there, but we truly are at a breaking point. And on your screen is an ad that came out from the Beaumont Hospital Systems in the midst of the pandemic, pointing out exactly that. We are at a breaking point. We've known it, we've recognized it, and now it's time that we actually do something about it. Just a few more numbers, and I won't spend a lot of time on this, but I did want to point out in your bottom left, the registered nurse shortage by state. If you look at for California, the supply will be about 343,000 by 2030, and the demand will be 387,000. So we're short about 45,000 nurses. And again, that's just nurses. If you look to the bottom right, by 2025, we're expecting a shortage of roughly 46,000 home health aides, 100,000 medical and lab technologists. So it's not just about nurses and doctors. Health comes in different formats. This particular slide, drivers of the healthcare workforce crisis, this could be an entire day's conference in and of itself. But what I really want to talk about is three of the big drivers of the healthcare workforce crisis. The first is an increasing aging population. We know that the over 65 population will grow by about 50% by 2032. It is expected to peak in 2030 at roughly 56 million people. That means we're going to have 56 million people that are over 65. Why does this matter? at least as it's related to the healthcare system. Well, people that are over 65 generally, and yes, these are generalizations, need more specialist care, usually have chronic medical issues, multiple medical problems that require not just one physician, but multiple physicians and an organized healthcare system to allow them to live healthy lives. And as people get older, they're not able to participate as much in their activities of daily living. So you will see the need for assistance at home as well. That is a form of healthcare. The second reason, the second driver, the healthcare workforce crisis, there's been a large exodus of healthcare workers from the system. And again, this has been briefly touched upon, but there's a few different reasons this is happening. Moral injury, which is my replacement term for the word burnout, because I think burnout carries a negative connotation with it that oftentimes puts it upon the individual, which is why you will see that I'm kind of phasing out that word burnout, though it does continue to be used throughout our system. Moral injury, unsafe work environments, administrative burdens, increased patient volumes as more people are showing up sicker, staffing challenges, wage issues. And then, of course, looking at this from an administrative finance lens, there are financial stressors in the healthcare industry. We did not come out of COVID-19 ahead in the financial game. There are thin margins. There are costs of hiring, retaining, and training staff. There's travel staff costs. There's depleted financial reservoirs, high turnover, and lost revenue. Briefly, we are aging as a nation. For the first time in US history, we are expected to have older adults outnumbering children by the year 2034. And this is going to be a significant issue as we begin to figure out how to provide healthcare for these particular individuals. Care needs change rapidly, providing for multiple complex health issues combined with age-related functional impairments. And we have a fragmented and institutionally dependent delivery system. That's really hard for older people to navigate. Moral injury. So to define it, moral injury occurs when we perpetrate, bear witness to, or fail to prevent an act that transgresses our deeply held moral beliefs. What is the belief in healthcare that is currently being transgressed? It's that oath that we all as healthcare workers took when we embarked upon the path as healers. That was about putting the patient first, about taking care of the patient. Who's challenging that right now? Well, quite frankly, it's everyone. It's the medical, it's the EMR, it's the insurers, it's the hospital, it's the healthcare system. It's our own individual financial security that comes from the difficult financial circumstances that oftentimes we find ourselves in. There's multiple factors associated with burnout amongst our healthcare workers, and this comes from the Office of the U.S. Surgeon General. Things such as politicization of science and public health, health misinformation, stigmas that are often aligned with this, misaligned reimbursement services, poor care coordination, lack of leadership support, and all the things that you see that are listed there. It is at a point where it is becoming and has become too much for our healthcare workers. And many are saying, this is beyond my control. And really, as a method of saving ourselves, healthcare workers are now stepping out of the healthcare industry. And I can say that from a very personal lens, from someone who did sustain moral injury, that I also stepped out of the healthcare world. I have since returned in a fashion that is more beneficial to me, but I can tell you there's many that are taking the same lead that I did. What are the solutions to moral injury? Well, remove low value tasks. You know, all the documentation, all the quality, oftentimes misdirected quality sort of products and paperwork and things that we are asking physicians, nurses to do, begin to remove those low value tasks. Engineer interprofessional teams who rely on robust supervision models. Make our collective capacity greater than the parts. Essentially what I'm saying, make 1 + 1 = 3. What do I mean by that? Well, we currently live in a world where we're trying to find cheaper replacements for everybody else. A physician can be replaced by, fill it in, X, Y, or Z. A nurse can be replaced by this person. We need to stop using that as our model, and we need to begin to develop interprofessional teams where everyone relies on everyone else with proper supervision models, allowing people to work within what is considered their appropriate scope, and then begin to provide healthcare. Use a human-centered, intentional approach to change, revise policies, and this one I will say it with emphasis, revise policy to ensure that there's no penalty for seeking appropriate care for wellness. If a physician has to fear some kind of medical staff action for going after seeking wellness in cases of substance use or anything along those lines, and there are punitive policies associated with that, we are not creating a well system. Acknowledge and combat racism, as well as discrimination that happens, that we all know happens in the workplace. Additional solutions for moral injury: commit to a coordinated approach to prepare for future public health emergencies. Disaster preparedness is key, but when you go to most hospitals, it is lowest on the priority list of things that we are actually trying to prepare for. Make sure that these kind of things are planned for appropriately. Recruit and expand a diverse healthcare and public healthcare workforce. We know that when patients are looking at people that look like them, their outcomes are better. They do better. Address the inequities, address the difficult access to care, increase funding for technological advancements, research on long-term impacts of the pandemic and well-beings. And for leaders, I would tell you, make sure you're joining the team on the front line. Make sure your boots on the ground so you know what your team is going through. Invest in the public health and public health workforce to address social determinants of health, health inequities, and countering of misinformation. So let's talk about increasing supply. How do we get more people out into the healthcare workforce? Well, change your educational model. Develop novel, creative, flexible educational models that are not rigid, that allow people to take on personal goals as well, or maybe address family-related issues. Break down silos of training and practice. Interprofessional education is now becoming a large part of healthcare training, and this allows health profession students to provide care in a collaborative team environment. I think many of us who've had to deal with either family members or ourselves in a hospital, we see this. One doctor will show up who deals with the kidneys, the next one deals with the lungs, the next one manages the diabetes, and the next one is the one that's globally managing your care. We need to stop. We need to come up with a more collaborative team environment. Incentivize primary care roles, incentivize healthcare workers to practice in underserved areas, and optimize the process of bringing international medical graduates into our system to serve with quality of care. How do we decrease the demand? This is where I tell everyone we need to put our efforts in. Decrease demand of our healthcare system. Redefine health. Help our communities redefine health. Health is not going to the hospital and getting your diabetes treated once you're at complications. Health is preventing the diabetes or managing it in the early stages by what you eat. Redefine health to emphasize primary and preventative care. Promote public health and preventative measures. Increase accessibility to healthcare, mobile clinics, street medicine teams, and focus on a more global approach to health that starts with teaching people, helping people, providing the resources to put the right food on their table, giving accessibility to parks and play areas, and employers who encourage healthy workspaces. Support community-based organizations that are already working in this space. And lastly, I would tell you this: policy is a large part of this. Shaping any legislation and policy will need to include healthcare workers, needs reliable, shareable data, and I can't emphasize this point enough. We need to begin with the right data. Increase policy initiatives to support human resource development. If it takes 6 months to bring somebody on in a job, that is not going to help. We need to streamline these processes. Encourage and support development of telemedicine, other technological advancements. Revise our antiquated funding policies for residency placements. Med school grad numbers have gone up, but Medicare funding training opportunities remain at 1996 levels. That does not make sense. And lastly, just as an example, as something in the space of policy, House of Representatives Bill 2256, the Resident Physician Shortage Act of 2021, which was meant to add 14,000 residency training slots over 7 years, has not had any action on it since 2021. Now, granted, we are, amidst the pandemic and all sorts of things have happened in the last couple of years, but we need to make sure that we push these kind of items forward, address the pipeline, expansion of training capacity, and build our workforce in rural and underserved areas. So where do we go from here? I will reiterate that it's the shortage of healthcare workers and moral injury from COVID-19 pandemic that are the two largest contributors where most of our efforts need to be. Solutions will be multifactorial, multidisciplinary, and require collaboration as well as fundamental changes. In my prep for this talk, I had spoken to Sonia and I told her if I could do it, I would just do a Control-Alt-Delete healthcare reset of our system. A successful approach needs to be data-driven. Health needs to be re-envisioned and start in the home. The finances, I believe, will follow if we create a more stable and reliable system. And moving forward will require us to work in collaboration with innovative and novel approaches as we begun, as Isabel said, to disrupt the healthcare system. Thank you all very much. I know I went over time. I apologize. This is a picture of the jacaranda blooms in Irvine, which I think many people recognize from all across Southern California. This is my email, my cell. Please feel free to reach out so we can continue on with the conversation.
Well, thank you, Dr. Sheikh, for sharing your wisdom and your valuable time with us. I feel as if we have a blueprint, and I know that a lot of the speakers today are going to resonate, if not identically, with all of the statements and recommendations that you made. Thank you for putting that so concisely. Next, we have a panel of leaders moderated by Shiv Gaglani, co-founder and CEO of osmosis.org, an organization he co-founded while a medical student at Johns Hopkins University. Shiv's company is uniquely shaping and disrupting how our healthcare workforce is educated. As a reminder to all participants, you can ask questions to any one of our panelists via the Q&A function at the bottom of your Zoom window. We will leave some time at the end of the coffee chat to answer questions. When inputting your question, identify what panelist with the @ and insert the first name you'd like to address your question to, and if you'd like, include your name and affiliation. I will now turn the microphone over to Shiv Gaglani, co-founder and CEO of osmosis.org. Shiv, the microphone is all yours.
Great, thank you, Dr. Becerra. It's good to connect with all of you. Thanks to Sonia and Octavio for the invitation as well and putting this together. And Dr. Sheikh, thanks for that keynote address. A lot of those things you mentioned resonate with me personally as well, and I'm sure with the panelists. So, building upon what Isabel said about my background, I was asked to share a little bit more about that, and then we can go into the panel and have the coffee chat participants or panelists introduce themselves. So I did 2 years of medical school at Johns Hopkins and was basically very frustrated with how inefficient the healthcare education system was. We were being taught in very antiquated ways with PowerPoint lectures, 60-minute lectures, and relearning many of the things we had learned in high school and college. For example, my co-founder of my company got a PhD in neuroscience before we went to Hopkins, and he had to sit in the same 6-week neuroscience class that the rest of us had to sit in, even though he probably could have taught the neuroscience class. And so that would have saved him time if he was able to test out of that. He could maybe be a physician 6 weeks earlier than he was able to. And so coming out of this, I gave this TEDx talk a couple of years ago called "Could You Get an MD Online?", which was essentially questioning how much more efficient could we teach our future physicians, and by extension, nurses, community healthcare workers, and all sorts of healthcare professionals. And that was the focus of this company, Osmosis, which I left med school for to grow. We grew to about 100 employees, over 10 million in revenue, a couple hundred partnerships ranging from New York University to UC Berkeley to University of Melbourne internationally. And were acquired a year and a half ago by a large publisher named Elsevier. And that's freed me up actually to go back to medical school. So I'm back as a third-year medical student at Hopkins, with the goal of maybe going into psychiatry or neurology, just given my interest in education and mental health in particular, which kind of ties into what Dr. Sheikh was talking about with moral injury and burnout. I think a lot of our healthcare professionals are facing that, and one of the main reasons they're leaving the workforce. And so I've just been very excited about the potential to keep innovating within healthcare education, but then also healthcare delivery. And I was also asked just to share a few takeaways from my own experience working to disrupt the healthcare education system. We have over, what started as a side project for about 120 medical students at Hopkins now reaches about, we have 3.4 million registered learners. We're the largest health education channel on YouTube. And you can see some of our content behind me. It's very accessible, very approachable, and we're doing a lot of not just healthcare provider education, but patient education and engagement as well. And so some of my takeaways from disrupting the healthcare education system, just to give you a specific example of how we disrupted it, at some of the schools we've worked with, NYU, University of Vermont, UCSF with UC Berkeley, they have a joint program. We help them transition from 4-year medical degree programs to 3-year MD programs. The 1.5 to 2 years of preclinical curriculum that students often went through has been reduced to less than a year without sacrificing quality, because we've been able to take these long 60-minute lectures and turn them into 6-minute whiteboard style, Khan Academy style videos that have been received very well with the rise of YouTube and Instagram and all these other kind of short form video media. And so 3 big takeaways I have. One is that kind of innovation has come to us from just combining ideas from different fields. So when we left med school the first time around and scared our parents, we wrote an article called what can medical education learn from Facebook and Netflix? And we grew up on a lot of these technologies and realized that the future of healthcare, future of media was becoming short form video, things like Instagram. It was also involving big data. So Netflix would be able to say, hey, if you like this show, you're going to like this show. And so we started incorporating those advancements into a medical education product that ultimately became Osmosis. So we really didn't innovate like out of thin air. We just borrowed concepts that all these other companies were applying and put them into a different context. So that's where our innovation came from. The second is we fell in love with the problem, not the solution. That's actually the title of a good book by the co-founder of Waze, which just came out this year. I think a lot of innovators in healthcare and education and other fields, they find a technology that they really like. Right now, AI is an example. And to them, it's a hammer and everything looks like a nail. And so they're really looking at a solution first approach to solving problems as opposed to a problem first approach to finding solutions. And so I think the reason we were able to do it was that we fell in love with the problem, which was healthcare education is inefficient. How do we solve that problem first and foremost? And then as we pulled on those threads, whatever solutions came out of it were what we pursued. And in this case, video form education, short form education, and a pretty cool platform that delivered that more efficiently. And the last takeaway I'll share is that we were the customers ourselves. So being the customer or putting yourself in the customer's shoes and knowing who the customer is, or the user, the end user, et cetera, is extremely important to I think in any disruption or innovation. There's many different stakeholders in community healthcare centers and just healthcare in general. It's the patient, the family members of the patient, the providers, the centers themselves, the insurers, the payers. And so I think it's really important that we all put, I think obviously we'd all say put the patient first and the provider first, put both those groups first, and then everything comes, good things will come out of that. And so being customer centric at every step of the way, I think was extremely important for us as far as innovating in health education. So with that, let me go into give it over to each of our panelists to do their introductions. I think obviously you've met Isabel, who will start and add maybe more color to this. Then John Cordova, who's Director of Workforce Development and Clinical Partnerships at Futuro Health, and Kevin Jackson, who's Director of Oral Health Leadership and Provider Recruitment at UHC Solutions. So first Isabel, then John, and then Kevin.
Thank you, Shiv. So again, President and CEO with the Coalition of Orange County Community Health Centers. My whole background has been, at least for the past 23 years, with community health centers. Shiv, quite frankly, I got to share with you that my career or my exposure started at Johns Hopkins at School of Public Health, working in Baltimore with the Healthcare for the Homeless Community Health Center. I did a fellowship with the National Association of Community Health Centers. It was called MATCH, Manpower Access to Community Health, which led me then all across the country finding my perfect FQHC to work in. And so FQHCs, in particular, federally qualified health centers, have been the backbone of my education and experience in the movement of community health. So happy to be here. I've been, again, with the coalition now for 23 years. And I love what I'm doing, and I love the topic that we're talking about. I love how we're crystallizing what the issues are as well as the solutions, and I feel very confident that we'll walk away with some sort of blueprint that we can then take action on. Thank you.
Thanks for that, Isabel. That's great. And also awesome about the Hopkins connection. Let's go over to John. Do you mind doing your introduction and then sharing a couple initial thoughts?
Yes, good morning. Thank you, everybody. I'm John Cordova, Director of Workforce Development with Clinical Partnerships at Fedora Health. I am a registered nurse by trade. I do nurse consulting, but also worked in community and public health and residential care. So really know the groundwork that's being done at the community health centers and in residential care needs. I was the former statewide director for the Health Workforce Initiative with the California Community College System, overseeing the 116 community colleges nursing and allied health programs. So really facing the other side of training and workforce development and that old hat, now in this new hat, working with scholars in a nonprofit organization to help get people into allied health careers. So really looking at both sides of the fence. And I really like Dr. Shake's thing about control delete because we really need to do a reset of the system, both in education, workforce training, and access to healthcare. So I think this is going to be a great conversation where we're going to have some really key elements. And this is always where I like to get on that soapbox because, really talking from that perspective of the end user or the patient or the advocating of the safety net so that we can actually get what they need in this realm of community healthcare. So thank you for inviting me today.
Thanks for joining us, John. And obviously, I'm a huge fan of Futuro Health, having met Vaughn and having your CEO, having had her on the podcast. I think you guys are doing great work. And last but not least, let's go over to Kevin, if you can give us your introduction and some initial thoughts on this topic.
Morning, everybody. Fantastic keynote speech, Dr. Shake. Hit everything on the head. I was literally glued to every word that you said because you summarized it and identified it in a very succinct manner, which I'm too verbose when I talk. So I really appreciated what you had to say. Thank you for the invitation to come and participate in this. Community healthcare is our only market. We at UHC Solutions, we've been around for 25 years. We recruit probably about 98% of our business is still with the community health centers. The only reason we have that maybe up to 2%, is probably not even 2%, is going back 25 years to the people who we started as our clients. We didn't abandon them when we identified what our mission was, which was to support the missions of the community health centers. We have 4 divisions. We do everything from the CEO to each one of the providers, the dental, the primary care, medical, and behavioral health as major areas. And then within each one of those areas, we go down to the actual user. So even in, for instance, finance in the C-suite, we would do a controller or a director of finance, somebody that's in the administrative section moving up. 4 teams, a very small group up here. There's only about 25 of us and running out of just south of Portland, Oregon, and Lake Oswego. And this is what we do all day, every day. We partnership with the community health centers to identify the right people that match the culture of each one of the organizations to put their key people into play. We have some CEOs within LA that we've assisted in recruiting to have them run those organizations. Now, some very large ones that are down there. Don't want to name drop anybody, but that's where we're at. We're very much in the trenches with each one of the CHCs to try to provide mission-driven providers and administrators to serve within the FQHC market to give us the outcome which we're all looking for, which is access to quality care for our underserved populations. We don't want to wait till it's too late when they end up in the ER and being treated in an acute manner when as Dr. Shake was mentioning, we need to give them primary care to prevent those things from happening. So early interventions, which is exactly what our primary care or our CHCs do. That's me in a nutshell. Currently, I'm focused as the National Director of Oral Health, but our teams and I have been a part of them, do all the different four levels. So I appreciate being part of the panel today.
Great. Well, thank you for joining us, Kevin. Obviously, you have a lot of experience. I think our audience will like to know because they have a lot of people across their community health centers they need to recruit. So let's start off with Isabel, but we want to make this as conversational as possible. So any panelist who has any thoughts on any of the questions, feel free to dive in and let's have a conversation. And also a reminder to our audience that you guys can write in questions, and we can hopefully have time to address those too. So Isabel, amidst the ongoing workforce crisis that we've heard about faced by community healthcare centers, what do you perceive are the primary challenges with attracting and retaining skilled health professionals?
Thank you, Shiv. So I think like many of the healthcare systems, community health centers are in perpetual recruitment mode for culturally and linguistically competent primary healthcare providers, healthcare staff. And I truly believe all primary care professionals are mission-driven individuals with the best intentions to go back and care for the communities and patients in high-need areas or where they come from. However, as we heard today, there are a few challenges the system faces with attracting and retaining staff. I think that first and foremost, it's the competition with other healthcare settings. So community health centers face competition with such as hospitals, private practices, and even non-health industries that offer more lucrative salaries, better benefits, or perceived career advancement opportunities. As Dr. Sheikh, referenced the mass exodus, from healthcare systems. Financial constraints. Many of the clinics face financial constraints that limit their ability to offer competitive compensation packages. This makes it difficult to attract and retain highly qualified healthcare professionals. And I would add also to this section in that not only is the competition hard for the primary care providers, but the lack of the career ladder opportunities make it so that, for example, health centers have only one chief medical officer. And so and even at that level, the competition is many times make it so that that individual or that CMO gets easily attracted, to recruited away to another institution. And the health center is again back in that perpetual recruitment mode, for that particular position. Workload and moral injury. I have changed all my terminology to take burnout out of my vocabulary and replace that with moral injury. So, as you know, community health centers serve a complex patient population base with diverse healthcare needs. Healthcare professionals in these settings may face the heavy workloads, high patient volumes, limited resources, and this definitely can contribute to the moral injury and loss of hope, impact on the job satisfaction and retention, away from what the original mission was, for some of the providers. I mentioned the limited career advancement opportunities. So for the health centers, especially the small ones, may have limited advancement opportunities compared to the larger healthcare organizations. And again, this may discourage healthcare professionals seeking opportunities for professional growth, specialization, or leadership roles. The next one, I believe, I often refer to it as community health centers being the best kept secret in almost every community that we exist in across the country. And so I think this is a result of maybe lack of robust HR or communication systems to not only elevate who the clinics are, but clinics with limited resources and infrastructure, including the absence of a robust HR, can result in challenges with recruitment, with onboarding, performance management, and career development process. If people don't know who you are and where you're at and what you're all about, it's very difficult, to access you. This is also can lead to not having good systems in place to have temporary workforce to address staff absences due to illness. At the end of the day, we and doctors are all only human, and life happens. And so if we don't have replacement or a way or system to make sure that there's coverage when life does happen, then that actually affects the ability to recruit staff or to make staff feel like they can take time off or they can focus on wellness. Speaking of, so lack of emphasis on self-care. I think as a natural instinct, CHC staff were helpers, always going above and beyond, and healthcare professionals working in the CHCs often face high stress environments due to complex healthcare needs of the patient populations that we serve. A lack of emphasis on self-care and mental health support can contribute to the moral injury and low morale. And thinking about the disruption, we operate in systems that cause the moral injury Yet systems with limited resources are unable to address the moral injury by providing system-level approaches to address self-care. The next one I would mention would be leadership challenges. Effective leadership is crucial in navigating workforce challenges and leading to transformation. CHC, similar to other systems, may face leadership gaps or leaders who may not possess the necessary skills or capacity to lead and inspire change. So investing in leadership development is crucial. And the integration of new workforce, such as community health workers, can be a transformative strategy, but it requires breaking old patterns or ideas of having a traditional workforce with specific education and skill sets. It requires letting go of job responsibilities that can be done by other types of workforce to help create more thriving and team-based environments. By using different workforce, such as CHWs, to assist patients more closely in navigating the healthcare system, addressing social determinants of health, et cetera, the clinics can improve patient navigation, patient engagement, patient navigation, reduce the burden on healthcare providers, and free up time for them to focus on more complex cases. So it's a plethora of reasons why there are challenges, and I'm sure we're going to get into that much more later. And I'll pause at that.
Yeah, I definitely resonate with a lot of those, Isabel, and I think you've articulately described all the problems. Two things I'll just share before I turn over to maybe John or Kevin to ask to add anything to your particular response here before asking an additional question. One is, I agree with you about the lack of the on-the-job training or advancement. Sometimes leading to terminal. There's only, as you said, only one chief medical officer at many of these health centers. I met a respiratory therapist who at one of these at a med school that we work with, who after 20 years of working as a respiratory therapist had to go and start med school from day one again because it's a different degree, and so all their 20 years of respiratory therapy didn't count towards streamlining their education. And there's certainly not as much on the job training to go from respiratory therapist to nurse practitioner or doctor, or that kind of differentiation that we see in other sectors outside of healthcare. And the second is, as I mentioned, Osmosis is now part of Elsevier. Elsevier is a large multinational corporation that did this really extensive survey this past year called Clinician of the Future, where they interviewed over 3,000 clinicians around the world. And there's a prediction that 75% of those clinicians believe that actually, the study said, I'm quoting from it, 75% of healthcare workers want to leave the profession in the next decade, so that they may want to leave the profession in the next decade because of things like moral injury, razor-thin margins, decreased compensation, et cetera. So the problems are vast, and I just want to add some color to that. Kevin, John, do you want to add anything else to this?
Yeah, I think one thing I wanted to add is that, one of the things we have to change is the mindset that healthcare only happens in the acute care setting. And we do that in both education, and we do that when we're training people. We train in silos, we train just to discipline specific, but we don't train to where access is really started in the community health. And so, we're talking about disruption. It's like we need to look at training and education providers to say, let's start by doing this. And I know it's tapping into, the moral injury of more people coming into the clinics, and I have to deal with all these other students. But if we're trying to shift, we need to make a shift all the way around so that we can know that students are, nursing students did not get public health until their bachelor's program. They don't get anything in the associate's degree or the generic program. So how do we shift that? How do we start putting some of them into community health and have access there to see what's happening there? There's a lot of happening there. I think Isabel started off by saying, primary care, dental care, mental health care, perinatal care, all that's happening in the community clinics. All that experience that you can get as an ongoing nurse, a medical assistant, community health worker, all those individuals can actually help into or building more cross-functional care delivery in those settings. So
yeah, that's a great point, John. Kevin, what do you want to add to this?
I you know, you guys are saying everything that I would think, and I've been in the education field. I've taught in medical assisting programs. I've been a program director of a Bachelor of Healthcare Administration programs, and you know, I think that John, one of the points you made is, you know, that's where some of that healthcare starts. Is, you know, not only teaching our new healthcare workers to do self-care, to realize their piece of the puzzle, but providing even way back then, set an expectation way back then as to, you know, that they are going to be a piece of the puzzle and they're going to grow and they're going to become the next provider, which kind of goes back to what you were saying, Shiv, about, you know, a respiratory therapist, which was one of our programs. They do want to advance their careers. And I think to kind of almost speak to what Isabel was saying is retention is really important. And it's a two-way street. As the administration of an FQHC, we know what the FQHC needs. Our vision a lot of times is from that side. Flip the coin. Look at the other side. These guys are bringing their careers to the FQHC market or to the hospital or to whoever they like. You know, they're looking for work-life balance. They're looking for, what are you doing for me and my career? Because I have a family I'm trying to support and I want to do this for an entire time. So thinking outside the box is probably where I spend most of my day. I don't think inside the box very much. I help CEOs and leaders at the FQHCs come up with policies, programs, ideas, committees to keep people involved. A small tangent, but I read this week a statistic in something online on LinkedIn actually that said an employee who has 6 or more friends where they're working stay working there. And we've all heard the opposite too, is people don't leave jobs, they leave managers, they leave supervisors. And so I think if you kind of combine those all up into a nice little ball and say, great, so we got to create an environment where people actually are friends with each other. We have to have managers who manage with motivation, not with fear. And we are looking at not only what the employer needs, but what the career of the provider is needing also, and providing that and come to a mutual, not just an agreement of, okay, this is what I'm going to do if you do this, but more of how can I help you? Some of my most successful CEOs or successful FQHCs are asking the question to the provider, what can I do for you in your career? What is it that you need? You know, they're coming out of the office and they're saying, you know, to the frontline provider that has 2 or 3 supervisors between the CEO and them, what is it I can do for you right now? Are you getting the things that you need to be successful and to make your job enjoyable, to provide our impact to these underserved populations? You know, so again, it's kind of reflective on what John and Isabel were both saying, but it's just so true. Retention's a big deal. We're not in the business of in recruitment. We're not in the business of shuffling them from one FQHC to another. That's not helping our movement whatsoever. We're interested in finding that new blood out there that has the heart and the mission values to come in, and then having them progress through the system, get promotional opportunities and things like that.
Yeah, those are really good points, Kevin. Thanks for sharing that. And you know, I love you kind of preempted one of the questions I was going to ask you and the rest of the panel, which was, you know, what specific examples of programs or strategies have you seen? You know, I know generally, you know, making a good work environment, making it friendly, but any specific examples, any of you can share, of things that health centers have done to differentiate themselves and remain competitive in attracting and retaining staff. And we can start with you, Kevin, and then Isabel and John would love to hear your thoughts on this.
Yeah, I appreciate that. I can give 2 really good examples from literally opposite sides of the nation, and almost different perspectives. We had a recruitment for, in this case, it was for a dentist. And it was in not just a rural California location, but it was almost a remote location. It was in northern redwoods of California. And their facilities, their 4 facilities, were spread out significantly. So they didn't even have colleagues right down the road or even in the same area. So getting the right person to be in there, we had to do a change thought. We had to do a reset in our thought process. Instead of saying, well, we've got to have somebody with 5 years experience or more so they can stand on their own feet and act as a solo provider, we said, what are we doing with our patients? What are our current patients' needs? And who wants to come here and practice that kind of dentistry? And so we literally took a candidate, or the person who won the opportunity was a resident grad in dental. And for those who don't know, dentists don't have to do residency. They can come straight out of school and start practicing. But this one happened to do a residency, 1-year residency. And as a part of the process, I already knew that the CEO in this case was very open-minded about letting the clinician practice to the limits of their scope, which included endo in this particular case, molar endo. And this particular candidate had just gotten done spending a year getting an opportunity that most residents don't. He had participated in 14 rotary molar endo cases. He didn't want to lose that. That's a very valuable skill for them. So when he did his interview, he said, I like doing rotary molar endo. I don't want to lose that. That would be a big piece of me coming there. And they said, do our patients need it? He says, well, based on all my research I've done, yes, you could do that. And they said, great, you tell us what it's going to take to get the right equipment in, the right materials in, that whole yards, and be willing to teach and mentor the other dentist at the 3 other locations on how to do this. And we'll do that. It doesn't cost the FQHC any, it's not going to put them in the red to do that procedure. It is a procedure that can be reimbursed at least a break even, if not bring a little bottom line back to revenue. So meeting that need for him really helped, and being open-minded enough to say, I'm going to help your career because you want to do this. And on the opposite coast, actually it was more in the Midwest, I worked directly with the CEO, and we have put into place a nice balance. So some things that weren't working was having the CEO who has to make the decision on these hires, asking all the people that have a seat at the table, interview this person, and we're going to decide as a group if we're going to hire him or not. That sounds like a nice inclusive environment. However, a decision has to be made. It has to be made by a decision maker, which is in this particular instance the CEO. And so we started including the other people, the direct reports in this particular case, in the process, but letting them know we valued their input for us to make a decision. So it took it out of this group vote where you were going to have multiple perspectives based on each individual person's needs, and it said, please provide your input because we need this input to make a good solid decision for the organization as a whole. And that CEO makes the final decision. So yes, when you get Susie or Johnny who says, gosh, I really don't, I don't want to work with this particular provider, or you get somebody else that says, oh my gosh, we just have to have this provider. I don't think we can do without them. All that's valuable input, but it isn't definitive of who's making the decision to hire that person. There's so much more into it. As Isabel said, retention is an ongoing problem. The cost of hire is very high, so we want people to be retained. In order to do that, we need to ask them what their needs are on their side of the stick also.
Those are great. Thanks for sharing those very specific examples, Kevin. Isabel and John, do you want to add any other specific examples you've seen?
Yeah, I'll take an example that I did with, prior to my statewide work, I was doing regional work as a director. And, one of the things I worked with was a FQHC in a small rural area that had a high turnover of medical assistants. And they just couldn't understand what, both leaving and having to let go because of skills and competencies. And so working with the community colleges in that area, I came in to do really a needs assessment. I said, first of all, let's take a look at what's happening here locally. Look at your incident reports. What are the incidents that are happening here as far as skills are happening with patients? So we took a look at that. But what we ended up doing is really taking a look at all that information, combining that, doing an assessment, finding out what it is that people were lacking in, providing training for skill competencies for all the medical assistants. And then within their staff, we actually were able to pull in lead medical assistants that their peers were all saying, yes, I like Isabel's going to be the lead for this. And Isabel, or Chip will do this. So that way there was some, camaraderie within that work group, but that person, Isabel, would be the one who was signing off the competencies on everybody who has to kind of make sure they're competent in doing the skill. One thing was like blood pressure cuffs. They were using the wrong blood pressure cuffs for taking blood pressure for kids or for adults and stuff. And those are simple things, but that does allude to patient's care and safety, because if we're not doing the right thing, measuring the right, vitals, and we're giving them the wrong to the provider, that's going to be detrimental to the patient. So we took a look about that, made some of them leads. They were able to provide them a little bit of a stipend for being a lead. And then with that, from the community college side, I was actually able to bring in more students to do externships, so that now that there was a certified lead, they were actually to get students. And over the 2-year period, they didn't have to fire as many people because they were more competent. There was an ongoing system within to do these competency skills with their medical assistants, and then they actually started doing it with some of the other staff inside that they built it internally. But it's really taking a look at what's happening there locally, and how do you support the staff that are there. And they will weed each other out. Some people left on their own because they knew that they were not going to be able to be competent, and they had several times to be able to build in that competency so that they can have drop-in sessions with that lead to say, I'm not sure how to do this correctly. Can you show me so that I can do it correctly? And so we made it a safe environment for them to also learn. But I think that's part of that. How do you build that retention into your current workforce, is looking at what is it they need, what kind of skills do we need, not what I think they need, but what really do we need to focus on.
John, that's a great example. Thanks for sharing that. And I couldn't agree more, based on my experience, in obviously workforce healthcare education is providing that safe environment, whether it's in the classroom or in the clinic, for someone to ask those questions, make those mistakes, and have those coaches or mentors. Isabel, do you have any, again, you work with so many health centers, any specific best practices you've seen for attracting and retaining the best workers?
Yes, thank you. I would focus on a couple of things. First would be to invest in the system and the people. I think that's been stated, but specifically building the capabilities internally around creating more standard and streamlined processes, clear communication around career ladder and advancements. I think people need to understand what the opportunity is, what the room for growth is, and I think better communicate what those goals are. I think to someone's example earlier around identifying what is it that they need in order to achieve whatever goal, right, the personal goals they have, for themselves. So better understanding what the mutual needs are, I think goes a long way. Then champion value-based care. This model creates a culture of accountability for the care of every member. It also gives physicians the freedom to provide the right evidence-based care for each patient, to prevent illness and reduce the incidence and effects of chronic disease. It allows for various types of workforce to be utilized in the team-based care model. I think this speaks to some examples earlier about making sure that as we provide care to patients, it's not done in silos, but rather in a collaborative approach. And I think that attracts more often than not mission-aligned healthcare personnel to the community health center movement. Speaking of the 6 friends you want to have at work, I think creating that supportive work environment, at the community health centers, we can create and support an inclusive workforce environment that values that work-life balance, promotes the professional growth, and prioritizes employee well-being. This can include implementing wellness programs, flexible scheduling options, providing opportunities for skill development and advancement, and for fostering a culture of collaboration and teamwork. I think the pandemic allowed us to finally recognize wholeheartedly that we don't have to be at work 8+ hours a day to actually get the job done, right? There are hybrid approaches that we can take that is better suited for certain individuals to still peak, in their job roles. So it used to be, right, there's an old way or old school way of thinking that in order for you to be effective and productive, you have to be present, your full shift. And we learned that that's not necessarily the case. We were all able to do our work completely remote for at least a good 12 months. And I think the recognition of continuing these accommodations and flexibilities go a long way, as we now know in all the recruitment efforts we see around us. And then again, investing in staff development, investing in our biggest asset, right, in our team and our staff. in ongoing development for them and opportunities, including trainings, programs, conferences, and workshops. And not as an exception, but as a rule that we provide these services and opportunities for all staff. We're supporting their growth and advancement of the workforce. We can enhance job satisfaction, increase retention rates, and foster a culture of continuous learning. So
I just wanted to add, because Isabel, you bring up a lot of great value and points here, but I think we're also missing a population of individuals who need to hear this, and that's the potential graduates from these programs. And often, as a past educator, I would try to go solicit, hey, do you want to come to do a guest speaking presentation to my class? I think it needs to be reversed. I think you need to start embedding yourself into local programs and say, I want to come and speak to your course, and I want to talk about community health. I want to engage you in what we do here. And I think that's another disruption. It's like, let me come to your classroom and talk to you what we're doing in this space, because faculty are not in that space. They only get to talk about it. They can't talk to it. And I think it's essential for you as the delivery of care there in the trenches is to be able to say, this is what we're doing here, and this is what value you can bring to us when you want to come to work with us. So I think there's a split in that.
That's perfect. Great, thank you.
Thanks. Yeah, that's a great point, John. And Isabel, thanks for breaking out some of those takeaways you've seen. John, since we were hearing from you right then, I did want to ask you, given Futura's work, specifically about diversity and inclusion efforts, because just this past week with the Supreme Court ruling, there's been a lot of discussion again around diversity and affirmative action, and the fact that we can't use race-based or are de-emphasizing race-based admission to higher education will have ramifications for then ultimately, our workforce in health systems and other industries. What are some best practices or things you want to share about recruiting maybe a more diverse or inclusive healthcare workforce?
Okay, well, this is where I might be the least liked person on the panel, but I think that it's not about race to me. It's about the socioeconomics, and it's about how do we give people access to education and training from an employee's perspective. If I'm working at said employer, I want to what we call level up or continue on my education, I have to go pay for that and then I can get tuition reimbursement later on. I can't wait for the tuition reimbursement. I need it now. So employers or agencies need to look at tuition investments as opposed to tuition reimbursement. Pay it up front. This is what we're going to do for you. I started my whole career in an earn and learn model where I worked 20 hours a week. I went to school 20 hours a week, but I was getting paid 40 hours a week. And I stayed at that job actually for 10 years because post that training, they continued to reinvest in me all along. That's why I stayed as long as I did. And so I think we have to kind of take a look at how do we provide this investment towards individuals as opposed to reimbursing them to do what they need to do. Not everybody has the silver spoon born in their mouth or have the opportunities. And one of the things that we also promote without even really promoting is this disproportionate inequality for people to say, okay, you're here, we're going to give you access to the education, but now you have to be at this level and you don't have the means to be at this level because I have childcare, I have this. I mean, as well, I mentioned something about, flexibility in education and how we're looking at models and stuff like that. We have to meet them where they're at. We have to meet them what we need to do as far as our needs. At your agencies, host a course. After hours, you have room available for students to come there. Allow them, education is always looking for opportunities to expand. So how can they come to that area and expand? Bring it to where the individuals are. They can't always go to the campus. If you're trying to engage in increasing the diverse workforce, look at local people who can't drive that far, but can come to the community health center and host classes after hours. So there's different things that can be done. And I think that, I always say it's not a race thing, it's more socioeconomic, is looking at what do we need to do to help that. And then when we hire, I think we need to hire for promotion, not hire for the job. We often are just hiring for that job, not what is Kevin going to bring to this employment, and where does Kevin aspire to go? What does he want to do, and how can I help get him there so that I can help retain him as well? So I think there's multiple things that we have to look at in this space.
John, that's a great example. Kevin, did you want to respond to that first, and then I'll?
Yeah, I'm 100% on board with you, John. And again, maybe it's because I also come from the education background, but for a provider has the ability to relocate. They have the financial means to relocate. They will move for a good job to another state. Medical assistants and dental assistants, they're not relocating for a $12 to $25 an hour job. It isn't happening. So bringing the programs to your facility, being a part of, in Minnesota, they have a state program for dental assisting. Being a part of that and bringing in your local community people and teaching them how to be a dental assistant, teach them how to be a medical assistant, using the clinic after hours for the lecture side, bringing them in and doing their clinical hours, their required clinical hours for an accredited program alongside your medical assistant, dental assistants. You're not investing $20,000 or even $10,000 in the program. You're investing it into the future of your workforce to be there, and you're not going to get it anywhere else. They're not relocating for a medical assistant job to a rural location. You have to use the people that you have in town. So just in those two job classifications alone, John, you just hit it on the head. And I actually used to be a program director for medical assisting, so it really hits me deep. I used to create partnerships from the college to the employer. And John, you're right. If we want to have them at the community health centers, they can be. We need to approach them at the education level. We also then get first shot at them. We've created a culture which they fit into. They're not going to go look for another job. They're going to take a job that we offer them here because they're already part of the team, part of the family. Again, I'm just reiterating what John said, but I can tell you from experience, this is how it works.
Yeah, there's one model that I want to share because this model and it actually kind of I won't say jeopardizes community clinics, but there was an area in Ventura that needed access to health. They didn't have it. So there's a medical assistant program. The medical assistant program, each week, Wednesday, they go to a church, they open up the classroom, the students do their didactic part of the classroom, and then at a certain hour, they break, they go set up the great room at the church for the clinic. And the clinic is then ran by all the medical assistants. Doctors come in to donate their time. They get put off into another section. And it's a well-oiled machine. I actually, as the community health nurse, I'd always heard about it. And when I went to go visit it, and then I left, I actually sat in the parking lot and cried because I could not believe the access that people were lined up to get access to healthcare. And it's like, how do we take that model and put that into where students can help serve your patients in more capacity, but also they're getting that learning experiences, they're learning more, and they're kind of taking the lead. They're learning these skills and leadership skills that they would not be learning in a classroom, right? But you're giving community access, patients are getting care, doctors are donating their time, the students are actually being part of the delivery, and it's just a win-win situation for everybody. I mean, so how do we take models like that and help supplant them within the clinics? I mean, from Ventura Health, we're providing scholarships to students. So I just went to a medical assistant program last week where we had 187 graduates. 82 of those graduates were Ventura scholars who graduated with no debt, who are walking into jobs with no debt. And I was looking at all the other students who did not have our scholar things on there and saying, wow, I wonder how much you're in debt. I wonder how much you're going to have to pay, right, for this job that we know doesn't get well paid, but now they're going to be paying this tuition, this scholarship, or the tuition back. And I have 87 people who are now in the game and can do that and start going on to other jobs or other career paths after they do that. The other thing I just want to say real fast is that we have to stop talking about pathways as being that's the only pathway. We've talked about several times, like a respiratory therapist who wants to be an MD. I actually one time wanted to go look and see how I can go to med school. And they said the same thing to me. Nope, you're a nurse, whole different model. You have to start from scratch. That's ridiculous. We need to build off of educational knowledge and skill, and how do we bring people bridge them into these other real pathways, not just deliver one pathway.
That's awesome, John. Really great points, especially like the one on debt, because that's obviously something that dissuades a lot of people from going into at least medical school, with the median debt of graduating medical grad being $200,000. So we're already at time. We probably could have made this twice as long and still not gotten through half the questions. So I did want to give every panelist the opportunity to maybe share one last comment, 30 to 60 seconds max. Just what makes you hopeful about the future of the healthcare workforce, particularly with health centers? There's so many things. For my point, I'll just lead, is I'm excited about the role of new technologies like obviously artificial intelligence has been in the news quite a bit. New York Times just published something this week where some clinicians are citing that AI type tools are saving them an hour or 2 hours a day from documentation, which is a contributor to moral injury and not having enough time to see all their patients, or dissociating them from their patients because they're have to document all this stuff with the EHR. So I'm hopeful that new technologies will help free up clinicians to actually be healthcare providers and carers as opposed to kind of admins. So that's my big innovation that I'm excited about. Let's go with Isabel first, and then Kevin, then John for what is something that makes you hopeful about the future of healthcare staffing?
Thank you, Shiv. I am hopeful because of the people that we got to meet today in terms of being in alignment with understanding what the issues are and what the potential solutions can be. I'm hopeful that we have a pool of talent that surrounds us, within our patients, our communities, our partners, back to the point of, let's not look outside the box, if you will, for people to recruit and train and invest in. They are already among us. And so that's what I'm hopeful. I'm hopeful that there are solutions in front of us that we can utilize to increase that, again, alignment with partnerships and grow our own, if you will, so that we can reinvest back into our healthcare workforce with individuals that are sorely needed on the cultural aspect, linguistic aspect. I think nothing makes more sense to me than bringing back into the workforce individuals that come from the communities that they will serve in. So that's what brings me hope.
That's great, Isabel. Kevin, and then John, and then we'll end with Isabel. Take us to the next chat.
I again reiterate exactly what Isabel said in this case. Those that are being successful are participating in conversations like this, whether it be in a nice large group like this that hopefully we can even grow and participate and take across the nation, literally from the grassroots that Orange County Coalition is doing right now. But you gotta think along these terms. Those that are being successful are doing these things. They're communicating. They're looking at both sides of the deal of coming to work for them stuff. They're looking at enhancing somebody's career from the inside. They're looking at internal promotional opportunity. And that doesn't have to be a promotion based on just income. It can be a promotion of, like John was saying, is you get to be the lead on this, or you're going to take point on this, and it gives people some ownership of their job and their career, and they feel appreciated. And the difference between being a manager in the college and being a manager here in recruitment and in my law enforcement career is, I have a different job, and my job is to know what each one of my team members needs and giving them that thing. And so I would say that's what our successful FQHCs are doing is they're not necessarily paying more than the next opportunity that comes along. Sometimes you have to get the right person, but they're then knowing what that person needs and trying to promote that for them. So maybe recognition, it may be money, it may be more work-life balance, it may be a lot of things, but we have to ask the question in order to find that out. So I'm just happy that some of our leaders are doing that, in particularly in community health, because it'll keep them from going elsewhere.
Awesome, Kevin. John, you want to take it away?
Yeah, I think I just want to reiterate, when we talk about, we're talking about socioeconomics as being, a driving factor, it is really looking at where they're living, where they're at. I mean, Dr. Anthony Abraham Jack wrote a book on the privileged poor and talked about the disproportionate inequalities that we're having when it comes to race, when it comes to ethnic communities. But when we're trying to serve our population with linguistically, culturally, and competent healthcare providers, we also have to be cultural, have cultural humility about what I don't know within my own culture. I can't say I'm very in tune to my culture just because of where I was raised and how I was raised in the Hispanic culture. But I need to look at what is it that the patient needs to have, and how do I embrace what I know, have humility into bringing to that care to the forefront. I think we look at socioeconomics, and when we look at, bringing people to, we can't just take them here and plug them in here and say, you're going to be successful and, good luck with you. We have to continue to meet them where they're at so that they can meet the patients where they're at, right? So that's what I'm talking about, is really looking at, there's that one diagram where you see the inequality with the person on a soapbox and this one's on a higher box, and how we make them equal to be able to see it through over the fence. That's what I'm talking about. We can't just say, oh, let me just put another box up there for you to look over the fence. What else do I need to provide you to be successful in continuing that trajectory for career pathways? So I think that when we look at disrupting this system, it's disrupting on how we deliver training, how we deliver education, where we deliver it, and are we giving them, part of what I think is, are education providers giving you what you need in these graduates to employ today?
Yeah, that's fundamentally a good question to ask for any educational provider, healthcare or not. So I'd like to thank the panel for the last 50 minutes or so for this coffee chat, and encourage anyone who's listening to reach out directly to Isabel, me, John, or Kevin if you have any other questions or comments. And with that, I'll turn over to Isabel to take us to the next session.
Thank you so much, Shiv, for moderating this excellent conversation. And thank you to our coffee chat speakers, Kevin Jackson and John Cordova. And thank you to all of you, all of our participants, for some excellent questions. To close out this Coffee Connection session, we have two amazing speakers, Dr. Michelle Balat, Executive Director of the UCLA IMG program at UCLA Health and David Geffen School of Medicine, and Dr. Roger Louie, Director of Medical Education at Altamed Institute for Health Equity. Don't forget to submit your questions you may have for our speakers via the Q&A function at the bottom of your Zoom screen, and be sure to let us know which speaker you'd like to address your question, and identify yourself and your affiliation. We will start with Dr. Balat. Take it away.
Perfect. Thank you. Are you able to see the slides? Hi, Isabel. Thank you for the introduction. Are you able to see the slides?
Not on my end.
Okay, let's see if I can share screen here. That's probably the reason. Let's do it here. There we go. Share screen. Now can you see them?
Yes.
Okay. And I don't have notes, and I'm sorry I can't get this other thing here. There we go. Well, thank you very much. And this has been absolutely inspiring. I feel so good after hearing what I've heard from my colleagues, but we do have a challenge before us. 3 key points I want to make here. Obviously, our keynote speaker did a brilliant job on the workforce crisis. How, I'm always asking, have we moved the needle? And kind of just a little close on what I think is some disruptive ways in which we can think about doing the work that we do every day on behalf of patient care and quality. So as we learned, we do have a primary and specialty care and healthcare workforce issue. We have the rate of state average for primary care is at 60. In some areas, that's where it should be, between 60 and 80. And some areas like Northern and Sierra areas, in the rural areas, they just don't have enough docs. And I've always been interested in the fact that lots of times in some of the rural communities, we have a kind of a more specialists. So I'm very thankful to our specialists, but I'm also, as a primary care physician, I'm a family doctor by training. I want to make sure that we make the opportunity for first line docs to be in communities such as we see on the right-hand side of the screen, where the left is showing you all of these different counties in our large state. But you can see a concentration of, for example, my specialty, you see there's a large concentration of family medicine residency programs. It's almost a maldistribution in some ways. And I think that ability to grow more residency programs throughout the state, as large as ours, is critical. Now, I am here today to talk about the International Medical Graduate Program, although I do wear lots of different hats and have been and am a board member of the Association of the California Healthcare Districts, and I also an elected member of the Beach Cities Healthcare District, so I work in that space. I have a master's in public health. I am interested in the workforce. I'm the first Latina of the use of what was a division of internal medicine to what became a department of family medicine at UCLA Health, after thinking I was going to spend my career as a county doc because I really wanted to serve my community. But as things evolve and people change and things happen, I did end up coming to UCLA because we were going to build a clinic within an under-resourced area. And I started to look at physician workforce more deeply. So this is a slide here showing that, by race, the difference in between the California physician population in the yellow bar and the California population in the blue bar. And so that far right picture was striking to me, that only 6% of the physicians that were in California licensed and active were actually that small relative to the population. So that was of great interest to me, because as stated by our previous speakers, there can be, with a lack of cultural and linguistic competency in healthcare, misunderstanding, delayed, even incorrect diagnosis, failure to convey clinically important information, confusion in medication and dosages, poor adherence to treatment regimens and follow-up, unnecessary tests and emergency room visits, and higher medical costs. And so in 2006, we started to look at the primary drivers. What did we want to do? We wanted to start to think about another way in which we were celebrating increasing the pipeline. For many years, there was what I would refer to as the leaky pipeline. We weren't getting people through high school. We weren't getting people then. If you didn't get through high school, you weren't getting to college. And God bless the community colleges, because without the community college myself, I wouldn't be been able to achieve what I have been able to in my career. So we wanted to look at the primary drivers for developing a program to address that gap between the doctors that could be in the community that were Latino, Latinx, Latinas, to be able to address the community, particularly given the large monolingual Spanish population that we have in California. So we wanted to improve the knowledge and awareness to California program directors of the benefits of IMGs in the respective programs. Why? Because there was a big stigma for international medical graduates. And we wanted to recruit and retrain qualified Spanish-speaking international docs to this program, with the overall goal of increasing the number for the state of California to go into family medicine residencies. So I think, as Shiv mentioned, people end up, and others, that there's a big debt and there's a big opportunity cost to go to medical school as it stands today. Many, many years at that top bar, you're going to get a bachelor's. Some people get masters, PhDs. They get into medical school. They got to go back to these 4 years, do residency training. In the international medical graduate world, most of the world does not train doctors the way we do. They don't go through that same ladder. They go to medical school basically out of high school. They spend 6 to 8 years. The international medical graduate has to get his or her required tests in order to compete for a residency program. So in between those little areas that are these, where those chevrons are, all I can think of, Shiv, is osmosis, osmosis, osmosis. So I think those are really important points that when we started the program, this program A, which that X is there, is that it was expensive. It had a high attrition rate. There was delayed matriculation for these international docs to go through training to get to where they needed to be. And imagine if you're new to this country, you're assimilating the language, the culture, the U.S. Healthcare culture, all of these things. You left Venezuela in, let's say, 2017. It may take you 4 or 5 years just to get on board with everything, and then let alone having to take tests that perhaps you had taken back in medical school many years before. And so we worked with a company, and we did well, but with the training, but we said, you know what, this is too expensive. We're going to have to think of another way. And what we said is, what we were finding, some of our best students were coming to us that had passed step 1. We got them into the step 2 CK, and after the pandemic, they have what they call an OET preparation. And we put that together. So currently, we don't have program A. We have the clinical sciences. We have the clinical rotations. And then finally, program D for us is when you're volunteering, doing clinical trial opportunities, and you continue with us up until what we call match, right? Doctors have to go through something called the National Residency Match Program. And our doctors, our trainees, our international docs that are really post-medical school, but pre-residency, we really needed to come up with this solution for this program. We have them stay in the program. And in return, what we're asking is for a commitment to practice 2 years, at least 2 years, in an under-resourced community in California. And there's a lot of papers written about, so how many people matched in anesthesiology, dermatology, family medicine, and people will talk about, well, we've increased by this and we've decreased by that. And, you know, after the pandemic, family medicine and emergency medicine both seen decreases in their numbers, despite having the increased number of applicants and so on. But this picture here shows us between 2017 and 2023. We started the program in 2006, but I'm giving you this snippet that it tells you the number admitted in the blue bars, the number that matched, and obviously the percentage. So it's really a kind of an unheard of thing that international medical graduates even get the opportunity to match in family medicine and programs or any program in the state. And there's lots of data to support that. But I'll just take a pause. None of this would happen without having collaborative relationships with the educators, our residency program directors throughout the state, who have gotten past the stigma, who have trust the knowledge of our graduates and say, you know what, we want more. And in fact, because of this, their area up in Bakersfield in Kern County, there was a very tiny residency program to meet the large Spanish-speaking population. And now the Rio Bravo Family Medicine Program is busting at the seams, and it's doing such great work. So we built that program because we were able to utilize our international medical graduates. So over between 2006 and to present, we've graduated, meaning that they've left our program, gone on to go through a 3-year family medicine training program. We have a total of 175 graduates. And you can see that, in the Central Valley, 65 of those 175 are there. So places like Fresno, Hanford, they are fortunate, and our graduates are fortunate to be doing great work in these various areas around where they trained. And there's an old adage, where you train, you'll stay. I think that was possible for my generation. I think people do move around a little bit more, but I'm happy to say that after the 2-year commitment, 78% of our graduates still remain in these areas of need. And I want to then just quickly talk about the purpose, a couple of things of disruption. And just like any program, all of us on this call have had to think about writing grants. Where's the money going to come from? Because that is the part that the grant makers talk about. What's the sustainability? And we're always scratching our heads. Well, you can't grow money on trees. So how do you determine? So this concept of the purpose of priority-based budgeting, I think, is a really important disruptor. I'm just using this slide from my colleagues at Beach Cities Health District, only because what we did is we transformed, and I'm thinking of your community health centers, and I'm thinking about my own program, without doing a way in which one does priority-based budgeting, and you sit everybody around the table, the doctors, the medical assistants, everybody, the students, and you say, what is it we do and why we do it, our why, and how do we do it and what it costs and how well we do it. And that process is available. And I would just encourage people. I am a big believer in, cost analysis. And I think the purpose and priority budgeting is a disruptor for many people, because a lot of organizations, it takes about a good year to get it off the ground. And I've left the website where there's a full presentation, which was given, I think, to the Council of Governance and some of the key cities. And this slide here, this disruptive technology slide, I'm gonna talk because we're our focus of this is what are some of the disruptions. And I really like this New England Journal of Medicine picture, because what it really did for me is it kind of centered these circles. These are in the center is where you've got your primary care provider, and these are the use. Now this is talking about disruptive technologies, and the bigger the circle, the more money that it's being market value. So, for example, for diagnostics in 1 year, we've got about $100 billion, or chart review and documentation, another $90 billion. And, all around us in the center, that primary care doctor and the patient and the payer employer, all of these things are running around us, right? So from things like device integration, which is about a $52 billion per year market here in the US, we think about when we all look at quality of care in our diabetic population, probably 25 years ago, we took a retinal camera down to we'll call it projects. I never liked that, but housing for individuals that were really under-resourced. And we were using retinal cameras because we knew patients couldn't get to an ophthalmologist. But here, now today, what was really entre nous now becomes mainstream. Now people want retinal cameras so that when their patients come in, they can get the pictures taken, and it can go off to an ophthalmology group that reads it, similar to what we do in many ways for EKGs. But as I'm thinking about disruption, and we think about even, how just like the EKG technician, right, and that's sitting in a room in a hospital, and all these EKGs are coming in. What other kinds of technical support are we going to need? Because every one of these disruptive devices is going to need people, and it's going to need a way in which people are going to be able to understand how are we going to drive healthcare? How are we going to do these things in a manner that we're going to get the kind of that quadruple aim of better outcomes, lower cost, improve patient experience, and provider well-being. And I think that in the center there on the PCP, and I like the primary care. There was a big group of people that said we don't like to be called providers, we like to be called clinicians. So I'm going to say the primary care clinicians, that we really want to recruit and expand, right, that workforce so we can meet all of those needs. Yes, we need to meet the quadruple aim, but it's who we do it with, how we do it. And I think that, as our keynote speaker mentioned, we have to really redefine what health is. I mean, you can see all the diagnostics, the chart reviews, so the Epics and the Cerners can collect data. but what are we going to do to drive the healthcare in a different way? And I think that this slide really speaks to me about the importance of disruptive technology and take that apart. But similarly, we need to have disruptive educational programs. And these disruptive educational programs, I'm using the model UCLA IMG, and there's others similar, but it goes back to one needs to have collaborators. And this is where policies and partnerships become important. And so I want to just quickly summarize because I want to give people the opportunity to ask questions. But, over the last 17 years, this program trains and provides Spanish-speaking IMGs or international medical graduates with an intensive course of professional instruction and clinical training so they can pass these tests. I'll be thinking more about how I'm going to shorten that up. These doctors compete successfully for these family medicine residency positions through the match. And in return, we want our doctors to work in these critically needed areas throughout our state. And of course, politics, these are concerns. We have a Supreme Court ruling, which these are going to put challenges and pressures on these types of programs, is my guess. So always having to think to reinvigorate and innovate and have voices of saying, why are these things still important for our communities? And I want to make sure that I give credit to my colleague, who was the former chair of the department, Dr. Patrick Dowling. He and I were the co-founders of this program. And I think that as medical educators as well, this whole issue of being able to build the residency programs, and of course, I'm going to talk to you about primary care because I feel that's important. And I would not say that building cardiology and any other ology isn't important, but we also have to think about who and how we're going to deliver care in collaborative partnerships and with a well-trained workforce, and well-trained in maybe not rooming patients, but how can we engage the patients in rooming themselves? So there's just different ways in which we can think about innovation and so on. And I really enjoyed Shiv's comment of how can we shorten up just education in general and make it more impactful and meaningful. So my time together in my career, frontline medicine, education, and serving the community is really what my career has been about. And I would love to hear from anyone that has questions when it's appropriate time. And I appreciate the opportunity to speak to all of you today.
Thank you so much, Dr. Balat. We will now move on to Dr. Louie, and we'll hold questions till the end.
Thank you, Dr. Balat. Thank you, Isabel. Good morning, everybody. Let me share my screen as well. Okay. Isabel, can you see my screen okay?
Yes, I can.
Perfect. So good morning. It's really an honor and privilege to be here today. My understanding is this is for the Community Health Center and FQ, my brothers and sisters out there. My name is Roger Liu, and I'm the Director of Medical Education in the Ultimate Institute for Health Equity. And I know we spent this morning discussing what we all know, that we need to continue to invest and grow our own healthcare workforce to serve our most marginalized and under-resourced communities. And for my presentation, really wanted to focus on what are those costs and investments for us to do this important work. And I strongly believe that professional is personal. The work we all choose comes from our own experiences. And I want to take a moment to let you know why I do what I do. Prior to Ultimate, I was on faculty at UC Irvine, the School of Medicine. And before that, I was a director and researcher in the departments of molecular and cell biology and integrated biology at UC Berkeley, where I completed both my undergraduate and doctorate. And if I were to attribute one key factor to my success, it would not be hard work or being smart. It was luck. Bumping into the right people at the right time that saw something in me that I did not see in myself. And Dr. Balat, I echo you. I'm a community college alum and wouldn't be here if it wasn't for them. And from that point on, for the past 25 years, it became my passion to develop pathway programs for students like myself that had the goal of serving the communities they grew up in, but did not have the resources, background, or family members that were doctors, professors, or researchers. And I don't need to remind all of us about the need for physicians, nurses, and behavioral health providers. And like you, I'm frustrated. I'm angry. For decades, we spent billions of dollars in grants, retention bonuses, pipelines to train and retain, but the problem still remains. We do not have a healthcare workforce that meets the demand of our diverse patient population in California and throughout the nation. And by the end of this presentation, I'm hoping to convince all of us here that we already have the answer to that important question right in front of us. All right, so like each of your organizations and clinics, AltaMed has a history, a culture, and a story. We've been fortunate to grow into one of the, if not the largest, federally qualified health center in the country. But we started off as a single storefront barrio-free clinic in East Los Angeles. And our mission, which I'm confident is similar, if not the same as everyone here, is to eliminate the disparities in healthcare access and outcomes by providing superior quality health and human services through an integrated world-class delivery system for Latino, multi-ethnic, and underserved communities in Southern California. Now, I'm the farthest person to be repeating a mission statement. However, it truly serves as our North Star and is a constant reminder of our purpose and our why. Now, we currently have 60 clinical sites throughout Orange and Los Angeles County, serving 500,000 patients with more than 2 million visits per year. We have 4,000 employees, of which 70% are women, and 80% come from the same communities of the patients we serve. And this goes from our CEO, Costello de la Rocha, to our CMO, CAO, COO, to our doctors, to our nurses, to our finance team, to our project interns. And it is this intentional belief that no one can take better care of our communities than those that come from those same communities is what I want to focus on today. We have over 350 providers and over 1,200 nurses. I was asked to talk about specific workforce programs here at AltaMed, and I've selected 3 examples with the goal of today's presentation not being a dog and pony show, but rather what were the lessons learned, mistakes made, and how can all of us work together to share best practices for how we grow and train our own. Now, I'm going to start off with training and growing our own physicians through the creation of our new family medicine residency program. Now, this significant investment begins with bringing in committed, passionate, experienced community medicine faculty from all over the state to come to Southgate, the heart of the community, and allowing them to build the program that they wish they would have had themselves. Then selecting the right residents that have shown a demonstrated commitment to serve the underserved. Not looking at MLE scores, not looking at if you have family in Southern California, but your commitment to serve the underserved. Now, if we're training physicians to be working in our CHCs and FQs, they need to be trained that way. And for us, that includes the maximum number of rotations in community family medicine and the minimum number of inpatient rotations. Remember, we're training outpatient doctors. I'm proud to say just a few weeks ago, we graduated our first class with 4 of the 6 staying as providers at AltaMed. Now, success for our program is not only being hired at AltaMed. For all of our programs, success is creating a workforce that is committed to staying and practicing in the medically underserved communities in all of our clinics. And we are proud to retain 5 out of 6 in an FQHC. Another significant investment we have made was in hiring grant writers and grant managers. Now, this allows us to only apply for those grants aligned with our organization strategies, making sure they benefit both our clinics and patients, and most importantly, that the work is sustainable. So we look at grant funding as starter kits. For example, we had a concern with our advanced practice providers having difficulty adjusting to our clinics, with many ending up leaving. So we applied for and received the HRSA-funded Advanced Nurse Education Workforce, or a new grant, which began in partnership with Cal State LA to bring family and psychiatric nurse practitioner students into our clinics to train. Now, we learned how difficult it is for a new NP graduate to transition, especially in our busy clinics. So we developed an NP fellowship where these trainees were pipelined into. And from there, we hired 100% of these well-trained Spanish-speaking NPs from the community to serve our patients. We now have a sustainable program that meets the needs of our organization, as well as having grant writers and grant managers that pay for themselves through including themselves into the grant budgets. Recently, the new grant renewal came out, but they changed it. They did not allow for the use of funds to support preceptors. So we only applied for half the money. And this is a very important point I want to make, that it is okay to say no to more money. We are often told the majority of grant funds need to go directly to students with stipends and scholarships. Now, coming from somebody I worked throughout my school myself, I disagree to that. We need to first take care of our preceptors, clinic team members, and whoever is going to support the administration of these programs. Another important lesson is that you have to have input during selection. We need to make sure if we are investing time, training, and funding in someone, that they have a commitment to stay and serve our communities. The last program I want to focus on is investing in current employees to allow them to continue to grow within our organization. Through a multi-million-dollar 4-year grant from HRSA, we have launched an LVN to RN pathway in partnership with American Career College. And the program supports scholarships for our employees and tailors their schedules to allow them to continue to work while going to school, as well as to accrue benefits, giving our dedicated LVNs who have been with the organization upwards of 20 years the opportunity to not only continue their education and receive their associate's degree, but making sure when they come back, there's a promotion and a position as a nurse leader already waiting for them. The program graduates are required to commit a minimum of 2 years after graduation. And most importantly, it removes the fear of hiring new nurse graduates. When I joined 4 years ago, we had a policy. We do not hire new nursing grads, even if they were Spanish speaking and it came from the community. And that blew my mind. Now we can, because we train them ourselves. All this creates a culture of growth and career advancement. People talk. When you see or hear others that have advanced, it changes their feel for the entire organization. Now, this is just 3 of over 50 programs we're currently overseeing in medical education since its inception when I arrived only 4 years ago. I was hoping to talk about our participation in the new Assembly Bill 1045 that brings physicians from Mexico to California to be licensed to practice for 3 years in our most underserved communities. And Dr. Blatt, I'm sure will be reaching out to you to talk to you more about that. And as we move toward the future, as Dr. Blatt said, the triple aim, quadruple aim, now the quintuple aim, Dr. Blatt, the quintuple health equity is now the 5th. They're going to keep going. Transitioning away from a fee for service to a value-based care payment model, where once providers would be conducting the majority of the care, realizing now that we will need a brand new workforce, including case managers, community health workers, disease managed specialists, and nurse-led visits. The question I have is, who is going to train this new generation of our healthcare workforce? And with the advancements in technology, I heard that earlier, and the future of healthcare, I'm going to push back. I'm going to push back and say it's always going to be all about the people and the connections and trust we build with our patients to improve their health so they adhere to their medication, develop healthy habits, and prevent their chronic illness. And for our patients, this can only be done with employees that come from the community, trained in the community by the experts, and that's us. So the ultimate question we need to ask is, what is the value of a mission-aligned workforce? What is the value of those intangibles, those characteristics you cannot teach, but we all know are in those special individuals that do not see this work as a job, but it's a calling? And how do we retain our current providers, nurses, and clinic staff and train the next generation, all while trying to keep the lights on in our clinics? I'm going to flip this question around. What's the cost of losing experienced staff or waiting for the system to automatically fix itself after decades and expect someone else to train our workforce? We're losing $1 million or up to $58,000 for every physician or nurse that leaves our organization. And with more funding than ever to train our healthcare workforce right now, as I said in the beginning of this presentation, we already have the answer to that question. And it was said here earlier. And as obvious as it is, the answer is us. We have the opportunity now to develop and retain the talent in our communities and those currently working in each of our organizations. Nobody knows how to care for our communities better than us. And nobody knows how to train our workforce better than us. Not any medical school, love medical school. I was there as a faculty. Not any university. They train great docs. They train great research, but not specifically to serve our community. We are the experts. We have an opportunity to work together, reimagine how we train, share best practices, and make the investment to grow our own. We are the answer. And we need to be sure this state and our leaders understand that we are here and we are ready to train the next generation. But it'll take more than student scholarships or additional spots in nursing or medical school. It's all about the who and investing in our clinic infrastructure, buying out time for our clinicians so they have the time to actually teach, funding coordinators, administrators, and managers to support all the logistics needed to run a program without further burdening our already busy clinics. The grant models are set up for academia, not for our community health centers. In fact, the California Medical Association has just created a brand new community health center mode of practice, which gives us a voice at the table to advocate for these changes. There are more than enough patients that need our help, that we don't need to compete with each other. And again, with the recent ruling on affirmative action, we need to work together now more than ever. And lastly, if we don't do this, who will? So I'm here as an ultimate leader and representative to say we are here to share and work together. Thank you for your time and this opportunity.
Thank you so much, Drs. Barlat and Dr. Louis. Our time together has come to an end, and I hope that you are as energized and excited as I am to take some of the lessons learned and begin small and incremental changes at your clinic sites that will disrupt how we approach the healthcare workforce crisis. Now, some summary points to help us continue to build the blueprint that was started by this morning's keynote. As Dr. Sheikh stated, we needed to focus on workforce shortage and moral injury, and we need to delete our healthcare system. To do this, we need to start by falling in love with the problem, as Shiv stated, and not the solution, and collaborate and partner together to address our challenge. As we think about innovating in the midst of serving patients and meeting operational needs, a key takeaway was shared by Shiv that was the innovation can be as simple as combining ideas from different industries. We heard from our coffee chat panelists that it's so important to invest in the people in the system. As shared, we need to manage with motivation, not fear. We need to go to the schools and share with them who we are. And we need to change mindset that healthcare doesn't happen in acute care setting, it happens in the community. We are truly at a breaking point. We have known it and recognized it, and now it's time to do it. As Dr. Barlat and Dr. Louis mentioned, we need to create more efficiencies, and we need to continue finding ways to create a healthcare workforce that meets the diverse needs of our community. Going back to Shiv's comment, we need to know the users of our system, community, staff. Knowing the people we serve and their experiences is what helps us with disruption. Ultimately, control, alt, delete can only happen through partnership and collaboration. At the Coalition, we are looking to start a workforce think tank to not only continue having these conversations, but to also co-design solutions. And I love what Dr. Louis just said is nobody can do the work that we do for our community but us, right? And if not us, then who? And if not now, then when? I think this is a great marching order, for, again, continuance of our blueprint. I want to thank all of our speakers today. Your insights, expertise, and passion for improving and disrupting the current workforce crisis is inspiring, to say the least. And thank you to each of you for participating in our third Coffee Connections event. Stay tuned for our next event centered around reproductive justice happening on Friday, September 29th at 9:30 a.m. Each of you will be receiving a survey where you can share your thoughts on Coffee Connections. And if you or your organization would like to sponsor our next Coffee Connection, we will be putting a link in the chat. And with that, I will say have a great rest of your Friday. Have a wonderful weekend and a happy 4th of July. Thank you.